Well, thank you all. I know that this session is the last session standing between you and dinner, and we're running a bit late already, so I will do my best to keep us on time. I'm very proud to be sharing the podium with two other colleagues, Dr. Thierry Fribourg from France, and also Dr. Shamin Kesserwan from St. Jude. So mine is the first of the three topics. This is going to be a shift toward a pivot, as it were. I like the term pivot these days from the politics, I guess, toward some of the conundrums and things that relate to the pragmatic aspects of genetic testing for Li-Fraumeni syndrome. And then I think one of the beauties of this series is also that Dr. Fribourg will be talking about the beautiful interface between functional aspects of P53 and the clinical phenotypic characteristics and how that all might relate to diagnosis. My talk is really a departure from all of the others because this entire symposium has wonderfully been about the concept of how do you diagnose and manage P53 carriers, and what does it mean to have P53? That's why the LFSA's engagement with this is so important, and I'm really honored to have been part of it from the beginning of the association and the genesis of this wonderful partnership. So I'm going to talk, though, about what are the challenges when we're in the clinic in terms of identifying P53 carriers, and this really comes from, just as Josh was saying, really focusing on the clinical aspects of what we're seeing. So what are we seeing using our clinical genetic skills to understand phenotypes and how that should stand as a cautionary note as we do testing. So when is T53 not Li-Fraumeni syndrome? So first off, we know that, and I'm going to reiterating what everybody has said before, and this is actually from the ASCO slide set from many years ago, but I've added to it the Li-Fraumeni syndrome core cancers. So brain tumors, sarcoma, adrenocortical carcinoma, and breast cancer. I'm not going to belabor them other than that we know that these four are absolutely integrated within the context. We know subtleties about which types of sarcomas are and aren't associated with P53, and there's specific red flags like choroid plexus tumors in a child that should really signal P53 testing as ACC would as well in a child. But when it doesn't fit that, we begin to wonder. And one of the challenges is that because 75 to 80% of what we see in our cancer risk counseling clinics relates to risk assessment for breast cancer in adults. It's just the way it is. This belies are really as a result of literally a couple of decades of testing and counseling for primarily hereditary breast and ovarian cancer syndrome. But now with technological advances, which I'll profile briefly, we have now this concept of screening very broadly. We always knew that if somebody had a problem with breast cancer at a very young age, that it was as likely to be P53 if they were under 30 as it would be BRCA. And so we've often done single gene testing based on age criteria or their family history criteria, where we do BRCA testing followed by P53 in the appropriate candidates if the testing for BRCA was uninformative. So along the way, of course, and Gareth showed some of this work as well, we started to develop what is the phenotype of breast cancer in P53 look like. And again, one of the first papers to come from the LIFE Consortium was, in fact, a paper that Maschiari and Judy's group had headlined for us, which was to put together the best number of tumors we could at the time, which was only 32 at the time, recharacterized the phenotype in terms of immunohistochemistry, and showed what Gareth so eloquently showed us earlier today about triple-positive breast cancer being the sine qua non of Li-Fraumeni related breast cancer as compared to sporadic breast cancer in the rest of the population. This is a paper that we published in 2009, which was from a molecular diagnostic laboratory experience of single gene testing for P53. The City of Hope lab was one of the first labs to offer diagnostic P53 testing. And in a series of over 500 patients, they found 91 carriers of mutations. And we sat down in 2009 trying to figure out, could we predict, looking at the clinical features, who was likely to be a carrier? And in fact, if you look at the top corner that I've highlighted, it basically says that if there were no core cancers in the individual or the family, despite a heavy cancer burden in the family, no mutations were found. So you had to have at least one person in the family who had a core cancer, and breast cancer is, of course, a core cancer, but I'm not sure that breast cancer at 55 is the same as a breast cancer at 25. In fact, we know it's not. So that was one lesson. The second lesson was we found that among women who got testing for P53 solely because they had breast cancer under 30 years old and were already BRCA negative, that 7% of those individuals had a P53 mutation. This resulted in a change in the NCCN guideline to be inclusive of P53 testing for women who fit that specific niche category. Now, and that's what's highlighted here. So breast cancer before the age of 31 is in the current NCCN guideline, and that's all somebody needs to get that subsequent testing if you're doing a gene-by-gene approach. Now, I'm, again, proud to be followed by Dr. Friborg, and this is from his paper that was published just recently. And I like the theme of revisiting Li-Fraumeni syndrome and what does it mean in this context. And all I'm highlighting here is that in the children, you see the core cancers that are common, and then the shift in adulthood. And I've loved the talks that I've seen here, talking about the different windows of susceptibility and the trends in different manifestations over time. This is really, we're understanding better and better the life course of what this looks like as a disease. So again, there's a shift, and so we should be thinking differently when we're managing adults as compared to children. But still, the top cancers are the core cancers. And he's going to talk a bit about predictive aspects of specific mutations in terms of what that looks like. So what turns out then is that with increasing use of multi-gene panels, it's broadening our view of the classic phenotype, or is it? And that is, a lot of us have been doing testing, and on a multi-gene panel, you just get whatever they get. And everybody thinks that more genes is better, not necessarily so. And we've been finding P53 mutations where we didn't expect them. And that reveals both management challenges as well as interpretive challenges. So I'll give you this example, and this is one of the cases that stimulated me to examine this more thoroughly. So this is a gentleman who's 79 years old. He is unaffected, never had cancer. You can see his family history here, and why did he get tested? Because his brother had pancreatic cancer and died of that disease at 79 years old. Well, in this case, this is actually a Jewish man. I would have thought that if anything was a worry, it would be BRCA2, since that can be associated with pancreatic cancer. But a clinician in the community ordered what's called PancNext. It's one of the multi-gene panels, and it included P53, and he had a P53 mutation. So pathogenic mutation, this is classic mutation, classic location, no question that the mutation that was detected in his blood sample was pathogenic. Now, what was interesting is if you got a little closer is that there's a comment. It says the results of the NGS, next generation sequencing, confirmed that it was there, but that it was in a ratio less than 50-50. And for heterozygous, it should be 50-50 even. So not only was I concerned about that note, and most people are going to ignore the comment on these tests. They're going to see the top line, and they're going to manage that patient as a Li-Fraumeni patient. But I said, not only does he not look like a Li-Fraumeni patient, nor does his family, but his test results also pose a technical possibility of other concerns, one of which is mosaicism of the true post-zygotic acquired type. We have many examples of that in genetics. Or is this something else? So this is that really led us to embark further. So when germline mutation is a surprise is really the concept. So the study we did was working with Ambry Genetics. We looked at the results of P53 testing for 85,000 patients who had multi-gene panel tests, and in that they found about 160 mutations, and then we studied those that had abnormal metrics, that is, less than 50%. And so basically, whole study was inspired by this observations of discordance and the fact that we might be overcalling, because with all the things you've seen, all the important things we're doing to intervene in these families, both to screen and to treat, it's important that we know what we're dealing with in an individual. So cases were selected from abnormal next-generation sequencing metrics. And what are they? Well, first off, this is somebody who does a diagnostic lab would understand this. You want good read depth, so you've looked at enough copies of the genes to be sure that what you're seeing is what you're seeing. And really what we're looking for is when there's a heterozygous ratio less than 20%. Now, that was our original inclusion criteria. We recently expanded that to 30% and actually doubled the number of cases that we discovered. And I'm going to highlight just our work to date on this. So we started with out of over 50,000 tests, there was abnormal P53 findings in 166. Of those, 140 looked like normal NGS metrics. You go down that, there was at least one that was a discordant phenotype, and that was a case that I have that I added into my talk, and I'll show you, that turned out to have something different. But the other side, with the abnormal metrics, now you break that down into decreased mutant wild-type ratio. That's most of them. And the other was that they found 2 p53 mutations in one patient. Well, that's homozygous disease, and we don't see that. So we knew that was aberrant to start with, and it turns out that individual, in fact, had some hematologic neoplasm in the blood that had not been appreciated when the test was ordered. So focusing on those who had the abnormal metrics, this is a list of those individuals. And I'll just highlight that if you look the second or third from the top, that's a 42-year-old who's unaffected. It's a woman. She has no cancer in a first-degree relative, and in fact, she had a mutation that was in her blood. Then if you go down the next one, this is a 67-year-old female who's unaffected, has some family history of cancer. The far right column is how many of them met Champray criteria or any other criteria we would have considered for referral to do P53 because we are suspicious of that problem. And you can see that only about 2 or 3 cases on the whole list actually would have met any criteria for recommending P53 testing to begin with. And so, and one of those is a breast cancer at 25, another one's a breast cancer at 31. So those are the things we could see. Now, we were able to get other tissues in those cases. So we were able to show that, in fact, the average age at testing for all these patients was 57, okay? So if they don't look like Li-Fraumeni by 57, we already have an issue. Second is that you can look among them that, sure, some of them did have some relatives with soft tissue sarcoma or the other types of Li-Fraumeni tumors, but they weren't prevalent, at least not in a large way, and certainly most of those were going to be second or third degree relatives. I think only one of them had, only one had a relative with a childhood cancer. Now, relatives tested, children were tested for many of the cases, and children were tested for 5 of the cases. And so a total of 15 people were tested for the mutation that was found in the individual, and nobody around those individuals inherited any of the abnormal alleles. So that would have been one way to establish that it was truly germline, that it was constitutional, is if you've passed it on or shared it with a sibling. So we've done a number of cases of ancillary testing where what we did was we went and grabbed tissues, other tissues. So in many cases, we'd do a skin biopsy, grow fibroblasts, extract DNA, and then look to see if that DNA had harbored the mutation. Another way to do that was taking the tissue from previous surgery, like a breast surgery that somebody had, not to look at the cancer, but to look at the normal tissue that was taken out with the breast cancer. And you can look at both tissues to see, is this a P53 mutation in the breast cancer that happens to be circulating tumor DNA, or is this a mutation in the constitutional tissues, the normal tissues? And so we did both of those. And so across the 26 cases that were part of this study, we looked at quite a number of cases that we had ancillary tissues on, and T53 mutation was not detected in any tissue or relative to date on any of the cases. And then when we expanded the look from 25 cases to 60 cases by increasing the mean allele fraction we're going to accept, we found one bona fide P53 mutation among 55 to 60 cases. So this really creates an issue. So I'll give you the example again here. So in my fellow with the pancreatic NeXT problem, this was his panc NeXT blood NGS, next generation sequencing, and Sanger results. And so you can see the mutation, and a little hard to read, but it talks about the percentage that were positive. Then we did Sanger sequencing, and sure enough, you can see that little red band in the second one down below. That represents the fraction that was mutant. Then we looked at skin tissue, so I did a skin biopsy in him, completely absent over 10,000 read depth. Then we looked at and this is both the NGS and the Sanger sequencing. And then I did a novel approach, at least novel from the perspective of using it for germline testing. It's hard. I don't like doing skin biopsies. I don't like to do anything to my patients that I don't absolutely have to do. And yet this study demanded that we really look at other tissues. And I was doing a PARP study for BRCA carriers where we're using eyebrow plucks and the follicle at the end of the eyebrow to get cells of epithelial tissue to look as a pharmacodynamic marker. And it didn't work very well for that study, but I said, you know what? I bet we can get enough DNA out of those to use those as an alternate source of constitutional DNA other than doing skin biopsies. And sure enough, we've been able to take the plucks and get over a microgram of DNA, good quality, and that was analyzed here. And it was a perfect surrogate for the skin. It matched the skin beautifully and, in fact, did not show the mutation. Both by Sanger and NextGen. Well, what was the time course for this man? Well, what was interesting is that in July of 2014, he had this sample drawn. His PSA was 3.5. His hemoglobin was 13.1 and normocytic. Well, 13 is just a hair low, but the rest of his white blood count was perfectly normal differential. He had a hemogram was the same, but suddenly his PSA started rising. And the only reason I knew this is when I saw him in July, and I was doing the skin biopsy and pulling the eyebrows, which he was glad to give up. They were pretty bushy. So he was no problem with that. He said, oh, by the way, doctor, next week I'm getting a biopsy of my prostate because my PSA has been going up. 16. This is really a high-risk scenario. And sure enough, he was diagnosed with prostate cancer the next week. I thought, that's it. We detected his P53 that was circulating tumor before his prostate cancer was actually clinically manifested. This is what we're talking about. That was what Josh talked a little bit about as well, the cell-free DNA. So he got the biopsy. I rushed the biopsies over to Ambry, and it wasn't there. We went to almost 50,000 read depth, and it was found enough to say that it probably was the inflammatory cells in the prostate biopsy that represented that abnormality. So it wasn't in his prostate cancer, it wasn't in anything else, and the same was confirmed by Sanger sequencing. So reality, and then review of the aligned data just showed that, again, through a depth of more than 10,000 reads, it's probably just the inflammatory cells in the biopsy section. So that brings up the concept that his P53 almost certainly originates in his blood. We couldn't find it in his skin tissue, it's not in his prostate tissue. Thus, and concurrent with this, in 2014, a number of papers have come out about something called clonal hematopoiesis. And this is the concept that over time, our cells evolve, and P53 is a driver mutation, and P53 is a very common component of CLL in particular. It's almost obligatory in chronic lymphocytic leukemia. Now, he has no evidence of that disease, but they took a elderly population, so adults of various ages, and the ages are listed on this graph, and they looked at sequencing of a lot of genes, and they actually did exomes, and then they did targeted resequencing, and they showed that there were a number of genes that showed evidence of mutation in apparently normal adults. And the top of that list was something called DNMT3A, but the fourth most common gene was P53. And if you look at this graph here, what it shows is that for an 80-year-old, which is the age of my fellow, that nearly 10% of those individuals are going to have evidence of clonal hematopoiesis as a perfectly well individual. And you can see here that P53 mutations in this study were the fourth most common mutations seen across this. So this posed one potential explanation for these findings. Turns out that those who had clonal hematopoiesis have an increased risk of leukemia. And while the odds ratio was over 10 times more risk, it's important to note that in the graph in the upper left, that's the difference between nobody having leukemia at the start and then 5% of them getting leukemia within 10 years. So the actual absolute risk is actually quite small, even though the likelihood of getting it is many times the average person's risk. So this points out that this may be either nothing, or it may be something in the future. And that's what now we call it clonal hematopoiesis of uncertain potential. And so that's just like a VOS, a variant of uncertain significance, but it's really about the blood. If you had more than one gene abnormal in your clonal hematopoiesis, you're more likely to get the leukemias. So, and that's really about subsequent clonal evolution. And this figure actually came from there. It was about a CLL case where P53, with that mutation, was the driver mutation, the first mutation in the cascade of others that were eventually acquired when this became a cancer. So I also had a case that had normal NGS metrics, and in this case, this is a lady with breast cancer at 58. She had a breast next panel, which included P53. She had a sister with breast cancer about the same age, but again, this is not a Li-Fraumeni family. But she had been reported to me as having a non-Hodgkin's lymphoma previously, and then her breast cancer. And so I got back her P53. I just said, this just doesn't look like Li-Fraumeni syndrome. And then I started reading her report was perfectly normal, no comments whatsoever. But as I'm paging through to do her dictation, I came across a bone marrow report. And I thought, why'd you get a bone marrow? And I read it had a 17p deletion. Well, 17p chromosome is where P53 is. And then I looked at her white blood count. I'm a hematologist as well, and it was like 18. And so if you look at this, it turns out that her blood result was perfectly 50-50. The next-gen sequencing from her breast tissue, which I sent to the lab, was negative for the p53. And do the math. So she's got a cytogenetic abnormality on p53. Her white count was 18,000 by the time I saw her for a second opinion. And it turns out that she has an early form of CLL that had the lymphomatous phase of that disease, but nobody had labeled it as such, so nobody knew it when they sent the lab test. So she's got CLL, and that's the problem, not the fact that she had the p53 mutation. So we have to be reminded that p53 is a part of multiple different tissue types. So here in colorectal cancer, and these circles refer to the overlap between germline and somatic gene findings among multiple different tissue types. And sort of taking that even a step further, then p53 is on all of them, by the way, was a paper that just came out within the last 6 months that looked at ovarian cancer patients and showed that ppm1D and p53 were found as what they called mosaics in the blood of women being treated for ovarian cancer. And there was a clear association between prior chemotherapy and subsequent manifestation. And don't forget that women who get ovarian cancer are older women. So they tend to be both elderly, so they could have p53 as an acquired mutation without therapy, or it could be a therapy related. And this actually showed as well that at least for ppm1D, unequivocally, you saw an increase in those mutations if they got chemotherapy as compared to those who were not chemotherapy treated. So it brings to mind this concept of mosaicism again. And I think of the classic version of it being the embryologic cell layers. We've had some beautifully elegant talks today about the embryologic layers and which ones arise and which ones have somatic mutations. Or is it something masquerading as a mosaic? And so we've termed somatic interference in germline testing. And these, by the way, I love Google because you can go on and get mosaics of all different types. And the crab I thought was appropriate for this. So genetic technologic advances are changing diagnostic approaches. Discerning germline and somatic mutations is an emerging challenge. Age-related clonal hematopoiesis, with or without incipient neoplasia, may explain some cases with apparent somatic interference. Emerging next-gen technologies are making it easier to find different things, and including cell-free DNA as a possibility, but we have to also be careful about what that means. Is it somatic interference or is it something in the blood? Additional tumors are being examined in our cohort. Somatic mutations can be detected in blood or saliva. Saliva and blood essentially are the same. It's basically the white blood cells that are in the sputum that we're measuring, so that doesn't help you. So you need other sources. Pay attention to the comments on the test report. And beyond this quality control, physicians need to recognize when results are inconsistent with what you see in front of you. And we need to basically parse away these cases in order to then ascertain the true phenotype of p53 in a much broader context. So ancillary studies of other tissue may be helpful. I'm glad that eyebrow plucks are likely to be an alternate to skin biopsies, and we're hoping to publish an SOP for using it in this context shortly in a technical journal. And then again, caution is urged in the medical management if the only criteria for LFS is a presence of a T53 mutation. And I've talked to Gareth and to Terry and others that we're really moving toward a definition of p53-associated cancer rather than Li-Fraumeni as a syndrome, even though I have great allegiance and great admiration for the pioneers of that syndrome. So again, we all need more collaboration. We really need to be able to gather as many of these cases together. I think the LIFE Consortium is an ideal place to put that. So again, we need more data on screening, more data on efficacy of clinical outcomes, but we also need to get a database together. So this is a continued call for cases. We're taking over the Data Coordinating Center as of this month, and so we have a combined, there's a LIFE DCC at coh.org, at cityofhope.org, where you'll be able to have a unified email contact for our team managing the database. And if anybody has other discordant families that they want to work on together, I'm very happy to acquire more cases for these studies. So it was the 30th anniversary of O.J. Simpson, and so it reminded me that if the glove doesn't fit, you must acquit. So if the phenotype doesn't fit, all right? I'm very indebted to my team, which is an awesome team of clinical cancer genetics professionals. They're listed here, including both our case. And then in the middle of this is our community of practice emblem, because we do a lot of training in the community. We reflect on community practices and standards and what the challenges they've faced. And most of my work really relates to pragmatic approaches to genetics. Thank you very much.